Hello and welcome to DHI4L. This is the Digital Health Innovations for Long Life podcast. It's great to have Dr. Balu with us. He is a friend, he is a classmate, and he is also a UK trained consultant psychiatrist and also won the Doctor of the Year award in 2018 from Asian Voice. He works across the United Kingdom, United Arab Emirates, and of course India, specializing in neurodiversity, ADHD and ASD, which I think during the conversation we'll expand a lot more. He also works with high performance mental health individuals who require the support. Also works on emotional wellness and integrative psychiatry. What sets him apart, other than the fact that he is a friend and a colleague, is that he has almost 25 years of clinical experience. He is also one of the rare doctors who has a MBA, that too from University of Oxford. He works in telepsychiatry and now as everyone gets into digital health, he also advises several digital health startup companies and companies that are working in digital health, especially in the area of psychiatry and luxury wellness. His present interest or his growing interest is in AI-enabled agentic mental health care or mental health care system. So with his expertise in psychiatry, working across at least three different, not continents, but countries and several probably countries across, he has a dual lens where he combines deep clinical expertise, organizational, financial, and technological understanding. And today we are going to talk to him about digital health, telepsychiatry, and all the ways that digital health can expand psychiatry and help people with mental health issues. So, welcome to our podcast, Dr. Balu. It's great to have you, and it's always great to talk to you. Uh, where are you kind of joining us for our podcast today?
Thank you very much, Dr. Suresh. It's indeed a pleasure and an honor for you to invite me and me to join you in this wonderful morning. So I'm today in the UAE, so Dubai in particular. So as you mentioned, I work across three geographies for now, and we do have clients from all over the world. And it feels like Dubai is now the new New York or London, where the whole world comes together. And we have nationalities, 200 nationalities, so many people, multiple languages. So indeed, for me, it's been an exciting journey. So joining you from Dubai this morning.
Well, I think being in Dubai and practicing psychiatry is almost, you can say that you are the psychiatrist now to the world, 100 nationalities. We'll kind of rewind a little bit and then go all the way where it actually began. So, if I can ask you, some people do refuse to answer this question also. When were you born and which year, where were you born? So,
No, I can tell you, there's no secret about these things. I was born in South Tamil Nadu, so in a place called Valliur. It's between, those of you who know geography, it's between a place called Tirunelveli and Nagarkovil. There are two districts, and it's a small town. And I grew up there, born in 1977. And the reason why we went there, my dad was working with the Space Research Organization, and there was a new unit that was coming up in the Western Ghats Mountains. And it was a fascinating experience. And I'm talking long time ago. And that's why we lived there. And growing up with rocket sounds and engine sounds, it was a liquid propulsion systems. And then as I was growing up, we kind of come from a very deep culture where there is a greater emphasis on education, discipline, and sense of community. So that's kind of the values that I was brought up with. And so it was a fun experience growing up. And when I was probably in my teenage years, if I remember right, many windmills started coming around. So sometimes, now, I'm talking in a conference about energy medicine and mitochondria, and some things that we didn't really do very much, in medical school. And I wondered, about these energy areas, right? And everything is energy these days, and the power and all of that. So, and particularly working in mind, it makes me wonder beyond biology. So that's kind of the initial interest that I had, and then
So where did you go to school then?
so it was the same place, it's a place, the same village, small village, and people were bringing in new things there, because it's a agricultural village, and so people were moving in, and schools were coming up. So we had a very small school. I only had about 4 or 5 people in my class going up. It's a very small school. You can't find many people there, and I always wanted to go to a bigger town, but there was never an opportunity. It was just growing up there. And then, after that, we met in Stanley Medical College. So from a medical school, then I went to Chennai, which is the capital of Tamil Nadu.
Well, I think we all graduated out of the same college, and then what happens after college?
Exactly. So, when you think about medical school, as you would agree, there was a lot of emphasis on clinical observation, a lot of complex issues. We didn't have the infrastructure that we have now to deal with stuff there. We have to adapt to lots of things. I remember days when we don't have, even the basic Venflon, or, just carry Venflon from one area to another, and then hoard them in your coat pockets. And we never really thought about huge systems until a time came when, towards the end of the postings, we saw 200, 300 people in a morning. And I thought, gosh, this can't be right. But there was no idea of, doctors getting burnt out or nothing like that. We all had a lot of fun. So, and patients didn't die in large numbers as well. So we were doing something right. But clearly, we didn't do much for customer service or, seamless engagement. The RSRM, the OBGYN, we have to stop a whole podcast about, customer services in OBGYN in Stanley. But that's a different story. But I was
the opposite of customer service, but then people are still happy, I guess.
Exactly. And people survive. So, even now I deal with complex systems, multiple complaints for the smallest thing. But those days, come on, it was a different experience. I thought there is still something to learn. But then from that, the transition was to understand systems, because I realized, and I was very confident, that without large systems, we can't deal with the crowds of people who are coming in. And so then I thought, the largest system, organized system in the world in terms of healthcare, was the NHS, and still is the NHS, although there are many systems now. So I thought, and I should go to the NHS just to learn the systems. I wasn't really thinking about specializing in any area. I didn't have a huge interest in pursuing only medicine. So systems thinking was my main agenda when I moved to the UK. So from treating systems to understanding systems organization, and I was interested in how technology and finance would help us. Because coming from physics, surrounded by rocket science, I'm thinking, can we apply this to health? This is the first thought I had, because of the crowds. So even in say 2000, I was thinking there should be no crowds in hospitals. That's what my thought was. But I don't know how I would achieve that. So I thought going to the UK might give me some insights.
Dr. Balu, can you kind of put a year to when you first arrived in UK, and when your interest in the systems thinking in healthcare, and also the interest in finances, which I think later in life we all understand that it's probably a very important component of healthcare, is not necessarily when we are in our Stanley Medical College, where finances somehow was taken care of by the government. So can we put a year to this and also understand how this thought process slowly started growing in you, and when did you decide to pursue an MBA in University of Oxford?
Sure. Yeah, and I will take you through that. So as you rightly mentioned, we were fortunate enough to be funded by the government to study medicine, and we were interns at that time. And it did seem like a lot of money then. I think we were getting about 2,000 rupees, which is not much now. You can't even have a good meal outside these days with that kind of money. But we were paid that for a month. But working in Stanley Medical College as an intern, we had the last year of our medical training as an intern. I was looking at a posting that we had in the intensive medical care unit, where we had to administer large quantities of atropine for people with organophosphorus poisoning. And it was a very laborious task. We didn't have the infrastructure that we probably have now. So there were me and two other colleagues, and we had to do so many injections. So we kind of sat down and devised a system. That was the first time I decided that rather than going back and forth to the nursing or the injection station from every patient, we will devise a system. So first time is system thinking. As you know, we're not really taught about system thinking in medical school curriculum. So following on from that, I didn't have a major interest in pursuing any particular post-graduation degree. And I wanted to really look at systems which can allow us to deal with the volume of patients we saw in the government hospital setup. And every place that we went to was crowded, right? Doctor's office means it's a crowded place. So that led me to my interest in pursuing a career in the NHS. And I left India in 2001. And I probably wasn't too sure, what I should really specialize in. The traditional paths available were medicine, surgery, but so mental health or psychiatry was the last thing I would think about, because we didn't have much exposure to that then. But there was a very good friend, who runs now the India's largest digital mental health facility called Amaha. So he was encouraging me to come and join him, actually just have some fun for 6 months, because they seemed to have a very cool job going in a place called Grimsby, and we had some amazing colleagues. So I thought, I'll just try it for 6 months and see how it goes. But speaking to patients there really changed a lot of things. So when I was really going through what was happening on the wards and how we were dealing with people with mental health problems, I quickly realized that we were dealing with the software of the system. We've always been looking at signs and symptoms of the body. We did talk a little bit to the patients then. Stanley was a busy time. But this time, it was different. The body was fine, but something was not fine. So I equated that to the software in the system, the software issue. So that really got me fascinated. And then I continued my training in mental health. But then the most important point that you mentioned, the money issues started showing up. Not personally, because obviously as a young doctor, a single doctor, you're getting paid a lot more than many doctors would get at that stage. And we were on a higher pay banding. So personally, we were having a good time. But when we looked at why certain patients were not able to have certain treatment, it all came down to funding issues. Although NHS is one of the best funded systems in the world, we still had a lot of funding pressures. Speaking to senior colleagues, it really dawned on me that there has to be another way to be able to fund this, because healthcare, I'll come to the difference between how I define healthcare and illness care. Healthcare may not be something that we regularly practice within the hospital setting. It's mostly illness care. And illness care is very expensive, because when you start putting money towards illness, there is no guarantee that you will return money back, right? So it's particularly mental health, it became a bottomless pit. You don't know what's the cost of treating a patient with schizophrenia or bipolar. So if you were to put a cost to it, the family wouldn't know how much to budget for. Insurance companies didn't know. Governments had challenges as well. So that was fascinating. So I thought, instead of going for my higher education, which means we go into a higher training program for 3 years, I decided to follow an entrepreneur who was building care homes, specialist hospitals, particularly mental health hospitals called Chai Patel, and he was building Priory at that time. So I went to work for him, and it was an amazing experience converting as a brick and mortar facility into a step down, low secure facility. And I learned a lot about finances, how you allocate funds and how you charge, and then how do you create value within the system for you to justify running a business. So every expense that we made should be justified. So that was an interesting experience. And I thought, I need to know more. So that's when private equity companies were buying some of these facilities, and the facilities were leasing back. So this buy and lease back options came along. So if you own an asset, you just sell the asset and then you lease back. So you released capital, you released money out. So from that experience, I thought I should do a full-time MBA. And by the time I thought, maybe I've done a little bit of medical work, and maybe I can work in management or finance and just quit. So I quit medicine and then joined for my full-time MBA at Oxford. And
What
that
was
was
this?
a fascinating experience. So this was in 2008.
Okay. I think we should talk about your experience of studying MBA, but before that, I'll also add up a couple of experiences of the crowded Stanley atmosphere, actually. I was, I mean, we are posted in a nearby PHC. If you remember, it was, I think, in the old Washerman Pet area, Chinna
Correct.
Stanley.
Yeah.
So there also almost like 50 to 100 people usually crowd up every day for this dog bite vaccines. And then it was unusual because of the such big number for a very small hospital. It was more like a outpost actually. And then I was talking to them, and one of them actually told me that most of them were working in the port, especially with these container trucks, and they actually sleep under the truck because as a cleaner there is a hierarchy. Driver speaks inside, sleeps inside the cabin, and the cleaner speaks, sleeps under the truck. And there it is actually a competition between the dogs and the cleaning guys because dogs also unfortunately sleep down, and then they drive away the dogs, and then the dogs come back and bite them. So every day you actually see at least 50 to 100 people coming out for the vaccines. And also, as you mentioned, along with poisoning cases, there will be a lot of tetanus cases also, which actually come. And you need to kind of inject the medications or anti-tetanus again, the dose several times during the day. And some of them don't understand it also. In fact, I saw a few patients literally walking out in the middle of the treatment saying, looks like a very small condition, and then you're just injecting so much of medications. And we don't duly explain them to the patients also because of the crowd. So again, the crowding was a serious issue, but as I mentioned, some of them understood, a lot of them did not. Some of them went through the process. Yes, thinking of systems is very essential now because, as we all know, population has fairly exploded in our country, and it has actually become a serious challenge on how to run healthcare as a system. So, looking back, we have these same challenges now. Partly in an administrative role, we also have to justify each and every expense that we are actually doing. And as a startup company, it becomes extremely important because we always try to do as much as possible with as little resources as possible. So finances, I think, should be an important part of medical college curriculum. In fact, very recently, when I was talking to the medical students, I was even telling them that every doctor, although he thinks that treating patients and talking to the patients is the important activity, he or she is also responsible for at least a team of 10 or 20 people who either are upstream to what he is prescribing or downstream where they are actually checking all those things. So in some ways you are already part of a system, and that's how hospitals are actually running these days. And systems thinking should be started up very early, and financial education should also be started up very early. Along with digital health, we are starting up very early into their curriculum. So how was your life at Oxford, and what further skilling up happened at Oxford?
So Oxford was certainly an interesting experience because we went back to living as students. So although I was kind of top of my career as a medic, and my wife, and we had a son, and we were all doing really well, we decided to donate a lot of our possessions and go back to two suitcases, Oxford as a student. But that was a fantastic experience. I was probably the only practicing doctor in a group of 234 highly accomplished people, so amazing individuals. And now, when you look at many of these people's trajectories, people have founded unicorn companies, become members of parliament and ministers in advanced economies. So very powerful, very interesting people. In 15 years, we have some amazing conversations with these individuals. And then 2008-9, I was going from a clinical environment into a business management environment. Steep learning curve, amazing experience. And what was even more fascinating was the type of people that came into Oxford to share their experience. So we had, the CEO of Sainsbury's, Lord Billy Moria of Cobra, multiple people, so many people, the presidents of countries would come in, Nobel Prize winners in Oxford because of its position, within the global academic circles, attracted these people. And what was even more fascinating was the Silicon Valley coming to Oxford. So 2009, we had the opportunity to host the Silicon Valley comes to Oxford, and we had Wisdom, Chris Saka, Elon Musk, for example. And we were all in a room together, talking about stuff. And what was fascinating about what Elon Musk was talking about, the first principle reasoning, and how do you apply in many industries, from physics. And, those days, Tesla was not a thing, or SpaceX was not successful, but he firmly believed in it. I still remember him being in his room, drawing pictures of cars without engines and petrol tanks, and, convincing everyone that, that would be the future. And he showed videos of SpaceX, putting rockets into the sea, not to space. And he believed that NASA would one day give him a contract. And that was really fascinating. And I remember him at that time talking about neurodivergence. It's an idea. Asparagus is an idea. And it was fascinating. For me as a behavioral science student, and I was curious. And I was at that time wondering if there is some eccentricities in these high-performing people that made them literally high performers and change makers in the world. They don't take no for an answer. They're almost eccentric, bordering on some kind of madness, but they believe in what they believe in, and they kind of forge ahead. And so that was a fascinating experience. And after that, you may or may not remember, Lehman Brothers happened.
Yeah.
It was a subprime, and the world changed. The financial world changed, and I was lucky because I had a healthcare background, so I managed to get jobs, within the healthcare consulting area, and I was working with a large family office investing in long-term care facilities. So senior care, specialist care, so autism, ADHD, children care, and they were also investing in food companies. So these are very essential fundamental businesses, which really, were thriving even when there was a financial crisis. But many of my colleagues, didn't really find jobs. So working in that environment was fascinating. Raising capital to deploy into again healthcare or care facilities, and looking at processes to return investment back to investors. But that's very important to attract more investment. So that was my primary area of work.
And so, if we kind of slightly fast forward today and then keep going back in our conversations, how do you think digital health is going to transform all those things? Not in the present, but if you have to step into Elon Musk's shoes today, which is, I guess, a very big shoe, or probably the biggest shoe in the world.
Possible, yeah, really.
and start imagining healthcare 5-10 years from now on, especially on digital health platforms. How do you think digital health will transform healthcare?
See, for me, when we think about digital health, when I started looking very carefully into digital health in 2012, I think it was more about video calls with doctors, or uploading your reports online, or some conversations of WhatsApp, or something like that. Yeah. But then I come back to this first principle thinking, where you break down complex problems to the fundamental truths to identify solutions. So now, what I'm thinking is a frictionless ecosystem. So healthcare, this is where I think we can have very interesting conversations and debates across the world. In my view, healthcare is simple. Illness care is complex. There are two different things. Yeah. So hospitals do illness care. So which means there are lots of comorbidities. There are lots of risks. When you go into a hospital administration, you're thinking, gosh, there's lots of risk here. People can die. People can commit suicide. People can harm others. This is what the hospitals and administrators are constantly thinking about. But if you do healthcare really well, you will prevent illness care. So that's the model that we need to think. If you look at the fundamental truths, just like how Elon Musk is thinking about space exploration in a very different way. He's thinking about cars in a very different way. You go back to what is fundamentally needed, rather than saying, well, we've always done it this way. So that shift hasn't really happened, and technology, in my view, has the potential to enable that to happen. So I'm dreaming of a frictionless ecosystem, not just video calls and uploading reports, and high functioning people. These people are the ones who put money back into the economy, and they have to be getting help without breaking the routine. So if you think about the number of wasted hours in hospital appointments, visits, road traffic, and high performing individuals taking their parents to hospitals appointments, waiting. Most frustrating, I can still remember from speaking to my dad, although when he had his, bless him, he passed away, but when he had his last days, in this world, he didn't really want to go into crowded hospitals. He didn't have anything against the doctors, but he wouldn't want to go into any crowded hospital. He said, no, I don't want to be waiting. There's a lot of people who get very anxious about waiting. And neurodivergent individuals getting structure and support, not shame, because they don't want to get into a hospital environment. Women in midlife, and I see a lot of them. If you remember in Stanley days, Kaikal Kodachal was very common. But, they're perimenopausal, they're brain fog, and so we need personalized tracking for them. And we could get Gen Zs, 53% of Gen Zs identify them as neurodivergent, they're unique. So they like asynchronous care. At 2 a.m. in the morning, they want to be accessing something, uploading their data. They may feel something that they want to share with a medical professional. So we need a asynchronous system, which is intelligent, always available. And another main thing is administrative burden should be properly automated, because many times doctors are very busy. They're giving you a computer and they're even busier trying to input data into the computer because some administrator is telling them that, and they hate it. No, administrative burden should be completely automated. So my dream is you improve access, you bring in precision, you offer continuity of care in a very empathic way, and you bring high level of automation. So these 5 things, in my view, when combined together, creates a frictionless ecosystem. Only when the digital ecosystem is frictionless that patients and doctors will adopt it. Otherwise, we'll always have this complaint that we are making things worse for them and not better. And when I mean healthcare, it's about really tracking data, preventing issues, and when they come in front of a doctor, they have all the data that is needed. It's not second guessing, So pure healthcare, if my health is cared for, I don't have illness. That's the idea. I know this is a pipe dream, because I also...
We are actually putting a framework to this. In fact, what we are trying to describe digital health is, because all the points that you mentioned is not going to happen in a so-called analog-based way. It's not going to be humanly possible. I mean, some people might say that it's humanly possible, but that's only to a very small population. If you are probably, treating or managing 5 patients, 10 patients a day, that's not possible. But at a systems level, especially with all the, you mentioned requirements of Gen Z, where they expect what you call access. I wouldn't say at odd times, but probably that's what people want. They actually need it. So yeah. I think all those things are only possible on a digital health platform. And the way that we are trying to even describe health is positive life and negative disease. So when you go to a doctor, it's all about, reducing the impact of disease, which is, this disease which has a negative kind of connotation to life. You have to reduce it as much as possible. But what people do not place value, importance, and resources on is also enhancing the positivity of life. And I think if you look at health as a mathematical equation, you'll have to reduce the negativity and increase the positivity, and both actually has, at least in our opinion, maybe a similar effect. But the challenge here is nobody knows what is a positive life, and positive life, this is where the so-called divergence substantially differs. Now, your view of a positive life could be different from my view of a positive life, to a positive life of the high-performing person and the positive life of a Gen Z person. So positivity has a very divergence, but at the end of the day, we can't actually ignore all those things and say, let's kind of meet only when the person is deceased. So that's maybe a unifying point, but there are multiple pathways to the positive life. And that's only possible on a digital platform because, as you mentioned, there is a divergent way people want to live their lives today, and it becomes, uh, I wouldn't say complicated, but complex. And as you rightly said, I think the only way to address a complex problem is to break it down into smaller, bite-sized, chewable components and start chewing each one of them and try to put them all together on a digital platform. In your practice, you mentioned that collecting data and the operational side of healthcare should not be a burden on the doctor as such. In psychiatry, and when you actually start talking to these people, there's a lot of requirements for documentation. And how do you think that part alone has changed over the last maybe 10, 15 years when you first started to practice psychiatry to the present situation where I'm assuming some kind of automation has actually come? And perhaps in the future where maybe an ambient AI can actually take in all that is happening between the patient and the doctor, and hopefully in a very controlled environment, in a secure environment. So, how has this change or the trajectory of change is actually happening? Can you kind of share a few on this?
Absolutely. So when even in the UK when we started, we still had a paper file. So we used to write the history.
How
So
long did that take? I mean, can we
yeah,
put number to everything here?
60 to 90 minutes.
Wow.
So a doctor can do 60 to 90 minutes, and they did 4 a day maximum, right? Because you get tired and you have to do all the documentation. And also, it was very important to capture this data for the payment, right? Otherwise, you don't get paid. Yeah. From that, things have changed dramatically. So, for example, the digital transformation happened, and then we were inputting all this data into a very clunky system. Many times, the frustration was that the doctor was required to collect demographic from the patient, where they are from, their job, their sexuality, and all of that. And that doctors found very frustrating. They're very happy to talk about what their problem is, how their problem happened, and all of that. And then you need to have risk assessment and risk management care plans, and very, very difficult to do personalized care plans, taking into account everything that they bring. So the patient will come to you with a 60-minute to 90-minute worth of data, and you would spend another 60 minutes to put together and make sense of it and come up with a care plan. By the end of 2.5 hours, you are half dead. It's not going to be possible to do that. So from that point, what we are able to do now is enable the patient to provide the demographic data in a form of a form. And then you have number of forms which will go in to the patient, and they can fill it at their own time, speaking to their family members. So the form is actually with them. And when the form comes to us, we have an AI engine which scans the forms, collects relevant information, makes a summary, and the doctor can then focus on what has not been answered sufficiently or go into a bit more detail on the concerns based on the doctor's knowledge, experience, so on and so forth. So it makes it very effective. So rather than me saying, welcome, Dr. Suresh, tell me about, your family, or no, I know that. Or tell me about, how you sleep was. I know that too. Tell me about your drinking habit. These are very difficult conversations. We don't want to know that. But we'll say, but I noticed that there is a change in this. And then you are saying, hang on, is it really? I didn't notice it. No, we do. And then you come into the symptom. So you're relating your symptom that you're seeing to something that's fundamentally happening behind the scenes, which becomes more easy to access with that longitudinal data. So, in a clinical situation, it's mostly cross-section. Tell me what's the problem. I have a headache. That's it. But here, I'm going into your hydration level, last eye check, your dental check, so on and so forth, stress levels, your all of that is there. So I'm then focused on one particular area that you need to address rather than spending time with all these things. So this has happened. And other major automation that has happened is we have a system that is listening to the conversation. Yeah. And once the consultation is over, you have a transcript and an AI then incorporating the history and the transcript and producing a report which can be personalized for the patient. I mean, this is the beauty. This is the part I really love, because you and your wife come for a consultation, you both will get completely different reports. Whereas in the old model, it will be cut and paste. I take some things from here. Okay, she's a female, so I'll put something there. And you will know that it is cut and paste from somewhere. But here, it is personalized. And when you come for the next time, it is even more personal because it is learning as well. So for me, the dream, again, this hasn't happened. Some of the things are happening seamlessly. You're a tech guy, you will understand this better. But it's not happening seamlessly. I'm talking about an ideal case scenario. This is what we want to achieve. Sometimes there are bugs, there are problems. But ideally, in my view, the systems should learn from the patients as they go along and continuously adapt. So in many ways, it makes the job of the doctor easy. So for instance, you come in, I'm not bothered with the history. I'm very confident that the history has been taken by my system. And I'm only doing the consultation, which takes 15 to 20 minutes, as opposed to 90 minutes of data gathering plus consultation, and then another 60 minutes of writing down before you get tired and you get burned out. But here's 20 minutes, and you click a few buttons, and the report comes up. So you're just checking the reports very quickly, make sure that it aligns with whatever you've discussed. So 5-10 minutes, you complete. So from 2.5 hours, you're reducing it to 30 minutes.
Well, that's a fantastic improvement, I guess. And that's where AI has actually substantially improved the workflow. But as you rightly said, I think there's a lot more that can actually happen to make this even more frictionless. But during the conversation, you also mentioned that me and my wife going for a counseling, which also hasn't happened, although my wife actually wants that. So I guess there is a lot more that human beings need to do, and AI also will need to do. But let's kind of fast forward, or maybe take one step forward. Even when you say, I'm going to manage this person, again, it's not a cross-sectional event. So even that has to be a longitudinal kind of a management, where this AI agent could potentially follow up the person and then start providing this extremely long intervention that you might have actually planned into, again, small bite sizes that can be conveyed to this person every day, or maybe if that's a bit too much, at least every week. And I think that's one area where maybe newer AI agents could potentially actually help. Thanks, Dr. Balu, for commenting about how the AI has actually reduced the treatment time, or probably the consultation time, from almost 90 plus 90 minutes, almost 2.5 hours, to 30 minutes now. But I think even the intervention that you would be prescribing to the person would be fairly something that needs to be followed over a longer term. And I think this is where AI agent could also reduce those interventions into sort of everyday consumable bite-sized interventions, or maybe if that is too much, at least once in a week. So what do you think would be the future of AI agents with longitudinal treatment after they start off with your consultation?
So I was going to say that you are an educator as well, and you train students, medical students, or the postgraduate students in digital health. And one of the interesting challenges that we kind of face, I'll go to the challenges first and then look at opportunities and how we address it, is how we address empathy, transmit empathy through a screen. That's a very important part of our consultation process. If you remember, in medical school, we taught about bedside manners. So now I think about this as website manners. So there is something that is an essential skill, if you're a health professional in digital health. So how do you then verbalize affirmation? How do you slow down your pace of consultation? And check assumptions explicitly rather than assume things, because the non-verbal aspect of the communication is not that clearly captured. And then you can give them structured summaries, digital empathy cues, and active presence. You have to really actively listen, because, it can be easily distracted, with technology. That's important. And giving you an example, and I think you ask a very, very important question. So I can give you a practical example from how I deliver this. So you are a high achiever, a professor, a consultant, a financier, a lawyer, accountant. And Many times these people hide executive struggles, executive dysfunction, the performance issues, burnout. I'm not talking about very serious health problems yet here. This is common issues that affects productivity for many, many people. They hide relationship strains. They hide circadian disruptions. They're not sleeping well, altered sleep patterns. They're having a glass of whatever, whenever, getting a bit of, hangover the following day. The traditional clinics, 9 to 5 or whatever, 5 to 9, long waits, heavy stigma, doesn't work for them. Like you said, you wouldn't want to wait in a doctor's office, although you know many doctors. The digital services allow for privacy, speed, and it fits around your work, but very importantly, like you mentioned, continuous follow-up. So we collect data, you have the consultation, and you have a personalized care plan, which would include a module on continuous follow-up. As you know, pattern recognition, tracking trends is more important than looking at a cross-section. And it also allows for asynchronous communication. We haven't talked about how this could be integrated into the digital wearable devices to collect data as well. So there's a number of things that we could do. And as you rightly said, the only way this can be delivered is through a digital medium. It's not an option anymore. It is the only way to do it.
Well, speaking of the digital platform to deliver service, I think we are also in another transition area, which is the rules that govern healthcare services, digital health services. And then there is a lot of talk about consent manager, especially with our new DPDP Act. And it's very hard to get consent. And it's very hard to get consent once. But if you have to kind of deliver this longitudinal service, how are we going to manage consent at every step? And then there is a lot of documentation also that is actually required. And then the documentation has to be done in a structured way. The documentation has to be also done in a relatively a machine understandable way. So although there are a lot of positives, and as we agree, services that are required in today's age can potentially be delivered only through a digital platform. But there are also a lot of operational requirements for digital services. And as you rightly mentioned, the operational requirements should not overtake the doctor's time. So how do we even do all those things? There
So
seems to be multiple challenges around.
there's definitely multiple challenges. So this is, as I mentioned, with complex illness care, which is unpredictable, unquantified, it is a huge challenge, when you try to get into complex illness care with purely technology. But smart hospitals, smart digital environments to deal with healthcare, I think is still a bit of a possibility. And I derive a lot of inspiration from companies like, say, Amazon or Uber, Spotify, where they're not just tech. They're tech companies, we know that. But in Amazon, it doesn't just sell books, right? It is this transformed, low friction. People love being on the platform. It knows a lot about us. It's very reliable. It's personalized. It's instant access. Shouldn't we, as providers of healthcare, and we are consumers of healthcare services too, shouldn't we be all aspiring for this low friction, high reliable, high personalization, instant access? And I can also give you examples from the financial services industry. In the UK, we have a number of challenger banks who don't have physical branches at all. Everything is done digitally. In fact, people have started to believe more in those banks, even compared to the banks which have a physical office, because you walk into an office, the guy says, "Can you please call this number or go online?" Then why are you sitting there? You couldn't do anything there. So I can imagine a day when healthcare, when you said about healthcare, you could be a diabetic. You just go by your little kiosk somewhere and get your sugar checked and everything checked and go off. The heart event can be predicted. Something gives you a message to say, hey, your whatever parameters is out of sync. Why don't you check in and complete this, rather than you have a heart attack and then call everyone and rush into hospital. So that would be the dream. It is possible, but I also feel that the traditional healthcare system. I was speaking to a medical student recently, and you are very much involved in the medical ecosystem. That means the education ecosystem. The learnings haven't really changed. They still learn medicine the way we learned. long time ago, right? So where is the digital awareness? Where is this need for systems thinking? There's nothing there. And customer service, no, it's still the old method. But when they come into real life, the real life is run by AI. So, there is a huge disconnect between medical education training and what the customers in the ground actually expect. In Uber, Amazon, Netflix world, you're still running the old analog model. That doesn't work, and that increases dissatisfaction. It also puts people off, coming to a doctor at the earlier stage. They only come when it is too late. So that increases frustration both ends. That increases financial costs, and it's a challenging model there. So you are absolutely right. It is not an easy problem to solve, but I have a lot of hope because colleagues in other industries have tried to solve this and are continuously solving this, and we should learn from that. And I take examples from, say, the airline business, where they're continuously improving to reduce or bring air crashes to zero. And we should be working in healthcare to bring critical emergencies to close to zero if we can, with high quality data. That would be the aspiration. We can do that. And people talk about safety of data. Financial companies are able to do it. The banks. I know of people who would value their money management more than their health management. But they are happy to part with their cash and get a digital number which would say X zeros, and they're happy with it. In the past, you would know this, people would only believe gold or actual currency. But now I can show it on a phone, that this is the amount in your account and you're happy with it. And India, with its UPI, has gone a long way in digitizing payment systems, right?
I think that's probably the best example of a so-called low friction service, where you just kind of wave your phone and then things get done. Let's also maybe briefly look at the so-called downsides of digitization, because as much as we say low friction and then high engagement platforms, there are certain things that do exist, and people seem to be getting pulled more and more into this AI companionship, which for some reason it seems to be low friction and high engagement, coupled with micro dopamine doses that keep on coming, where people seem to be get sucked into this. And also with the e-commerce, I think people seem to be placing a lot more orders than it is actually necessary. Along with the fact that there is now an emerging psychiatric situation, I guess, where there is also what you call social media, the equivalent of drug abuse, social media abuse. Can we even use that term?
Addiction, technology addiction is
technology addiction. So I think these are all emerging areas. So that's one challenge. The second challenge, which I think you might be more aware of when you are practicing in multiple countries, is the complexity of rules that multiple countries try to come out with. These are two challenges, if you can maybe highlight on how we can potentially address them. I think that would be very helpful.
Absolutely. I think we'll look at the second one as a system challenge. The challenge is in EHR implementation. So you have geographies which has strict privacy rules, the HIPAA, GDPR. And then there are geographies which have mixed systems, deliberately, because there are some people who don't want their confidential medical records into a secure system. The GCC region is quite a good example of that for the right reasons. And in India, it's all fragmented for multiple reasons, right? And everyone has their own system. And the interoperability issues, the non-portability is a huge problem. And also with global travelers, people traveling from one geography to another, if they end up in a new geography, they become a new patient, although they have a history. So some kind of a health passport where you can carry it with you and then plug into a system would be a solution. And then interoperability issues are a huge concern. So you're absolutely right that this is a major concern. But coming to the other point, that is a very, very interesting area because, I work with colleagues who are into AI ethics, for example, human AI, and like you said, technology addiction. And I specialize, in the clinical practice, I specialize in neurodivergence and conditions where people are seeking dopamine. So ADHD, for example. So I always say, as a healthcare practitioner in the neurodivergent space, I'm competing with Netflix, competing with Amazon, competing with Starbucks for treatment because they are proof that there is a lot more neurodivergence in society. Because, like you rightly said, the repeated ordering, although people are intelligent, they know what they're doing, but they're not always doing what they know. That's where the addiction comes in. You know very sensibly, having one drink is great. That's it, go home. But no, sloshing yourself down. And using all sorts of scrolling, doom scrolling, they call it, right? You're saying, look, I'm not actually deriving an information by accessing this. I'm feeding my emotion. People talk about walking their emotions, eating their emotions, and seeing their emotions. So that is what they do. So if you use technology to modify your emotions, well, you need to talk to people like me. So that is when the addictions start creeping in. Technology is good, but overuse or abuse, well, that's the thing with anything in the world, right? It is here to stay, but as humans, we have to be sensible enough to use it for good rather than let it feed our dopamine urges, and that leads to addiction. People talk about withdrawals from this. If you switch off the Wi-Fi, people get fits. Really, that level of consumption is there. And even now, when you go to a coffee shop, you don't order a coffee first. You ask for the Wi-Fi password first. And many times, I was at the coffee shop recently. He said, "Buy a coffee is my password." So he said, "What's your password, please?" I said, "Buy a coffee." So you buy a coffee first.
I think along with ordering for a coffee, if somebody asks for Wi-Fi, then you should also kind of give your card and say, "Please do meet me."
Exactly. So this is fascinating, isn't it? So for me, digital discipline is important. Like with anything in life, right? People talk about food addiction, sugar addiction, all sorts of things. So digital addiction is a real possibility. We can have another podcast on this completely interesting topic, because how the companies design apps and websites and programs to really capture your attention, give information in bite size, like you said, give you the dopamine surges. If you're sad, you can be binge watching Netflix. We never learned about this mechanism in medical school. How does binge watching Netflix cure your sadness or help with your sadness?
When we were kids, if you binge watch Doordarshan, you are definitely going to be sad.
Exactly. It's a completely different world now. And I haven't certainly learned this medical school, but we haven't. But my question to you is, are your students learning this? Because that is the world that they are going to enter, and they are going to be responsible. So if we have a conversation with your students 25 years from now, they should be having solutions to all these problems that we are talking about now. So that is your responsibility to educate them on these.
That's the next part of the podcast for me to ask you the same question. At Mallaredi Vishwavidyapit, you know that we have started India's first school of digital health. And along with starting our bachelor's, master's, and PhD programs in digital health and medical robotics and several other areas, what we are also trying to do is engage with the medical college students, the dental students, nursing, pharmaceuticals, allied health, and hopefully engineering also, where we want to bring this idea of digital health to all these students. And I was about to ask you the question, what do we teach this? Because as you rightly said, nothing much has changed since we were taught medicine, which I think if we look back 94, so it's almost 30 years before. And maybe very little has actually changed. But if you want to bring in the change, what are the things that you think should be taught to these students?
So I am not here in this situation. You are the expert, but I'll make an attempt. And the attempt is based on my experience of somebody who's a user. So you are the expert and I'm the user. So I'll give you some user perspective, user feedback. Sure. See, for me and for us, medical school taught us clinical safety. We want to check for red flags, for example, risk management. That's an important part of what we do. Pharmacology, prescribing medicines. And as I said, bedside manners, interviewing skills, treat people with respect and make them feel comfortable, so on and so forth. But we did not learn what we call as digital empathy. That I think has to be a part of the curriculum. When you meet somebody online, they should feel that they're listened to, they're connecting with you. It should not be disconnected, And telehealth protocols, that's very important. And like you said, you're aware of the hardware, the software, the process they use, and whatever geography that you're working, and so on and so forth. Just like how there are clinical processes in hospitals, there has to be a telehealth protocol. You not just open your laptop on your Skype, that's it. No, there are many, many things in there. Art of online communication, there has to be a module which looks into this. Yeah, this is very, very important. Just like how you would teach communication skills, soft skills to students, and as you know very well, Dr. Suresh, it's consultations that are curative. Yeah, anyone can collect the data, and we call this Kairasi doctors. Why? They had this wonderful, method of making people feel at ease, and they heal, right? And then we need to really focus on this important area of remote risk assessments, which will give the regulators a great confidence in our system. Because you only need to have one or two things going wrong, and the whole system, the public, will come at you in a big way. So remote risk assessment capabilities have to be built in, and we have to have processes which we can audit. Data ethics, ethics of safeguarding all this important data. People shouldn't leave and steal and put it on the internet or sell it on Facebook or use that to blackmail people or send. Because I've had situations where data about a spouse has been sent to the other spouse, and that has been in Thailand or going somewhere else. This is private confidential information, sexual health information, very, very important, so that is important. And how do you really collaborate with AI agents rather than see that as a competitor or an enemy or having a fight with it? Like a harmonious couple, you need to have that loving, understanding relationship with AI, because AI is a tool. You have to have this AI collaboration mentality, the mindset. And we need to really looking at productivity gains. Not just I'm in a web chat like with my girlfriend or my friend. No. This is a paid consultation. Every minute counts. And am I making those productivity and improvements for me, for the system, for the patient? So we need to have a metric which can measure that. And in my view, this is something I think you guys will be leading on. The operational design of a digital health system has to take into account many of those things. So there's no good in just you having a physical hospital and put some gadgets in it. That is not a digital hospital. It has to be seamlessly integrated. So, for example, you will agree that there is a huge difference between a store which has an online, ordering process, compared to a digital company like Amazon. Amazon's systems and operational design is very different to, say, Reliance Mart having an online ordering mechanism. It's very different processes. So, in my view, I certainly didn't learn any of these things in medical school, but I see the need for all of these things if I'm recruiting somebody who is digitally aware or digitally proficient. Yeah. So I want digitally proficient doctors. So you need the medical skills, but you also have this as an add-on for them to be easily deployed within the digital hospital. There will be a lot more digital hospitals. For example, in our service, a telepsychiatry service is 100% digital. We have nearly 1,000 staff and $100 million business. I know it's small, it's very small, but it's 100% digital. You understand? So that is something that I would really encourage you to very systematically look into.
I think, these are all absolutely wonderful points. In fact, as you kind of put the burden on me when you started off, I would definitely take this up. And then I think one of the areas the school should be focusing on, and we would be doing that, is to create a kind of a structure and a standard for all the things that you mentioned. In fact, as you rightly said, now we need to figure out how to even behave ourselves online, and there should be a structure for it. In fact, very recently I was talking to a student in SRM Public Health, School of Public Health. I don't actually remember the topic, but the broad idea is she was actually doing a research on what are the challenges people face, which for us might look funny, but apparently these are real. When there is a delay in response when people are communicating digitally, if there is a delay in that small blue ticks, or if people don't actually respond in time, how much we would call it as inconvenience, but people unnecessarily go into depression because people don't respond, and people exclude certain people in groups, and then they don't respond to certain specific people, and they talk to only some people. So I was actually talking to that person, and I think as much as we focus on these challenges, but as you rightly said, what we need to actually find out is come out with some kind of a protocol on how do we actually need to behave digitally, especially in a professional environment. In a personal way, I think there is a little bit of what you call a gap that people might understand. But as you rightly said, if services are turning 100% digital, then there needs to be a protocol to say that you need to respond to people in X amount of minutes. Is that doable or not? We need to so-called create a backend environment where all these requirements apparently are actually met. And I think this is also one area that we can actually collaborate, because all the points I wouldn't be coming up with, although it would be my kind of job to come out with a structure. But when I come out with a structure, also, I think I need to take it with you and say how much of this is, good, bad, or I think this has to be a two-way, conversation, or a continuing conversation that we can perhaps work on.
Absolutely. See, I am coming in from a user point of view. You are the expert, right? You are the academic professor making these modules, but I'm looking from a user point of view. You touched upon something very, very important that we see because we have a lot of experience doing this digital work for like 10 plus years, and the thing that you specify is what we call as RSD, rejection sensitive dysphoria. So what happens is when people have a delay, they perceive this as criticism or abandonment or rejection. So, for example, I've sent you a message. We're having a nice conversation. I've sent you a nice message now, and I don't get any response. But in your end, the internet is down, or you're going for a coffee. You're doing something. You have nothing against me. But I immediately think, I have said something wrong here. Suresh has blocked me. Or whatever. You go into that catastrophic mode. It's called RSD. And yesterday I was having a conversation with somebody about this dysphoria. It's not like a little, inconvenience, like you said. It is dysphoria. You should look up that. It is instant, deep, unhappy, as if you've broken up now. Well, we've never been in a relationship to be breaking up, but that is the intense feeling they have, RSD. And you also have some of these people have something called PDA, not public display of affection. That is a different terminology. This is persistent demand avoidance.
Okay.
So if you ask them to do something, you are not getting them to do it. So that is PDA. PDA and RSD, again, Gen Zs, a lot of neurodivergent people who are tech savvy have this in the background. Yeah. And that kind of generates these kind of issues within the technical world. So what we do is I can give you some snippets of the website manners in a module, right? So when you start the conversation, you have some ground rules. You discuss that. So I tell them I'm so and so. I can see that my screen says you're so and so. Do you have a form of ID? We kind of discuss some pleasantries, and I say in the digital environment we can have disruptions, delays. So we're kind of accommodating that. And sometimes I have a screen nearby. I have some paper. So I tell them, look, I've got these things around me. So I'm looking away. I will be intently reading something because, I want to come back to you on that. So please bear with me if those things happen. And that kind of settles down because it is not personal. Suddenly I look at somewhere or somebody comes and then I'm talking to them. It is not nice, right? Because we are having a conversation. So I kind of put that in the context. I say, I might get some help from someone because there's a lot of gadgets around me. But you are my priority. You tell me what you need. So that kind of sets the tone. And also, when what is interesting is I've had many conversations. When people express an emotion, they start crying. For example, you don't know if something you said made them cry or somebody else, whatever their environment is. You cannot assume these things. There are certain things that you take them through, and you can really affect that. So I always say to people who say, with the digital health. But I will say, have you ever cried watching a movie? Have you really met Shah Rukh Khan or Rajnikant or Amitabh Bachchan or whoever? No, you haven't. Well, you know a lot about them than even your spouse. How do you know them? Right? They are all digital icons, right? And why don't you think if Shah Rukh Khan was doing your therapy, do you think you'd be unhappy or happy? I don't know. That's different than Deepika, but you talk about whoever you want. So I'm saying, how can doctors be so in tune with it? I'm not saying that they should become actors, but they should be having an avatar, a web presence, and a digital, discipline, or whatever website manner we call it. And there should be a lot of case-based learning, how we used to be in our postings when the patient comes in. And I still remember Professor S.K. Rajan only interested in how the patient's welfare is. Has he eaten? Has he come from a long distance? That sort of niceties, And we should also have supervised digital clinics. So, for example, you as a digital expert will have, like how they do the driving lessons. You sit by the side, you have your brakes and things in control. And when your student is actually doing the consultation, so you have supervised digital clinics.
I think that's a wonderful idea. I think you should trademark that.
I don't know. We can do it together. So the thing is, again, interdisciplinary teams. I think you mentioned that. Putting architects, engineers, clinicians together, because let these guys see the other guy's problem. Because he's sitting in one lab, he's creating something fantastic, which will never work in the real term. Let this guy say, look, boss, this is what I'm struggling with every day. Can you please get some solutions, And, we need to really bring in behavioral science and design as a course, The UI, UX, should really go with human behavior, And of course, you need to have some proficiency in the tools, AI tools, whatever the tools that you're using. But, it's very important. And I visited your simulation center. This is fantastic. But you have that for the physical health. Again, do that for digital health, digital simulation centers.
I think next time when you come, I think we will also have a VR lab where, as you think, you mentioned, I think we'll create a separate section for supervised digital clinic. I think that's a fantastic idea. We should work on.
Correct. Yeah. So there's lots more we could do. This is just the beginning. And honestly, I am only sharing it from a very layman user perspective, because I'm on the ground. And for me, I have great interest in translating what is in the lab into real world examples. Because, when you're in the ground, you see a lot of frustration. You think, why are these people's lives wasted? I feel so sad when you really see somebody whose life could be changed. Say, for example, if you are an aircraft, crash investigator, you say, oh, if only that switch was flicked, this would have changed. And there's only one switch. And in healthcare, we come across so many near misses. Yeah, and digital health is the only way to, humanly, it is impossible.
That's absolutely right, Dr. Balu. And I think our conversation is also nearing the 90-minute mark, or probably crossed now. So I think we need to probably schedule another 90-minute conversation sometime.
Anytime.
But I'll get back to you after I do my 2.5 hours work of transcribing this conversation. It's been fantastic talking to you, listening to your experience. And also all the wonderful points that you actually mentioned. I think we'll probably work together and see if we can come out with a structure. And it's absolutely necessary. I don't.
For me, because you are the expert, what I would be very happy to contribute on is how to reduce friction, increase access, enhance continuity, integrate other data from different modalities and mechanisms, supporting high performance brain. And how do you make this care global and portable? That's important, So if we can capture that in our course, I think we are doing a good job. I'll be led by you, because you are the beacon of hope for all of us in this digital world. And India, I think, will lead the world.
Yeah, putting a lot of what you call pressure on me now. So
you are the capable one. We are all foot soldiers in the ground, looking at this, right? You guys are the air cover support. So we are looking to the planes that fly above us.
No, that's too much dopamine for now, Dr. Balu. We'll pause now.
Yeah, all the best.
Thanks a lot. It was wonderful talking to you. Thank you.
Lovely. You take care. All the best.
Bye.
Bye-bye.